Hello, thanks for joining me today. I have thought that it would be useful to share with you a presentation recently given at the 2021 Path Visions Conference in Las Vegas. And so if you'll allow me, I'll share my screen with that presentation queued up, and we'll talk through a little bit about pathology training programs. The title of the talk, obviously not your grandmother's training program, how to go digital and virtual with pathology education. This is a topic dear to my heart, but as we think about this, I think you need to know that I don't have a financial interest in this fight, but I do certainly have a personal passion for expanding the realm and quality of pathology education worldwide, not just within the confines of my own program. So with that, I identified a couple of objectives that maybe you, depending on your circumstance, could find useful. One would be to identify some new digital pathology teaching or learning resources that could be of value to you personally in your learning or teaching of pathology. Secondly, would be to learn how to describe what remote learning opportunities might be available and how those resources might be able to potentially impact many of the health inequities that we see in the world today. And finally, hopefully recruit some interest to joining this effort to add value to and organize some of these digital pathology educational resources in a manner that can truly have an impact on some of the big problems of our day. Now, this may seem like abstract art in the sense, but I'm hopeful that by the time we conclude that things are clear, properly jointed, and not only beautiful, but edifying for you. First of all, let's start and say, is there a manpower problem? Well, I think this article from 2018 was trying to explore that question a little bit further. And Rob Boy and his colleagues demonstrated that we did have a large number of open positions. That's a pretty large position of unfilled, or pretty large portion of unfilled positions, even when you discount those that were being discontinued. Especially when you consider that, nationwide, there may only be about 2 or 3 times this number of positions that are filled for training. This means that we have an excess of about another 25% of positions that are going unfilled with current trainees. Now, that can be a good thing. Certainly a healthy job market prompts employers and both to make their positions competitive, payers to be mindful of those issues and so forth. But it does portend maybe some further problems down the line if this is to continue year upon year. On the other hand, if we look worldwide, well, the situation changes dramatically. And yes, your help is wanted here. The manpower challenges in Africa just illustrated in these numbers. Estimated number of pathologists, somewhere over 1,000. That's tenfold less than the United States, but a population that is several times, even orders of magnitude higher, and estimated numbers of cancer cases certainly projected to be monumental by 2030 based on World Health data. So we could say here, help is desperately wanted here, and in so many other areas of the world where the portion of pathology services that are available relative to need and demand is staggering. And this is because we have begun to see decreases in many of the infectious and contagious diseases, getting a handle on some of the issues in terms of chronic diseases that have plagued the developing world for so long. And as that's happened, and as other standards of living have increased, the proportion and length of proportion of cases of non-communicable diseases like cancer and ischemic heart disease, stroke, and so forth continue to increase. And this is playing out really in a rather unrelenting fashion throughout the developing world, much more so than in the developed world. Well, given that, I think we can see that there is a tremendous manpower shortfall and a rising caseload that is going to demand some fairly stiff changes. And we can't just assume that these things happening far away are not going to affect us in the developed world, because COVID has certainly illustrated that in more than just the scarcity of toilet paper or a few other commodities. We need to be thinking about ways that we can make pathologists more productive so they can accomplish more work with the tools that they have. We need to also be thinking about how to how to train more pathologists and provide and deploy them in more places. And that can happen by increasing the rate of training in existing programs. In other words, graduating more trainees on a more continuous, shorter time frame schedule, perhaps, and increasing the number of training programs or the capacity of those existing programs. Now, it's also possible that there will be some paradigm changes in disease or diagnostic and therapeutic issues that will change the demand for pathologists. This mitigation is unlikely to be of the order of magnitude that we need to be able to properly provide the services. Similarly, efficiency gains, even if you were to double the efficiency of pathologists in the developing world, you would be a long ways short of the demand and need for those services. So we asked the question, how do we make pathology education more efficient and more available? Well, let's talk about efficiency first. Efficiency of learning and attaining competency. If I think of my two exemplary residents that I've dealt with over the past couple of years ago, this was the norm. Micro would come through, he would handle GI cases as they came through the door. Whatever polyps or whatever got biopsied that day, that's what he saw. And if he had time, he would preview the slides beforehand, review and read anything that might be pertinent, maybe show a couple of his colleagues, other residents and so forth. And as a result of that pattern of learning, after about 2 months on SurgPath, he could accurately diagnose about 60% of lower GI polyps. One of the foundational steps, I would say, in developing surgical pathology expertise. Now, fast forward a couple of years and introduce a digital pathology-based tutorial on the classification of GI polyps with a modest number of examples at the beginning of the rotation. And Pico here, he goes through then the same process, takes the GI cases as they come through the door and signs them out with the attending at the microscope and does his reading and so forth as appropriate. But after even just 2 weeks on surgical pathology, his diagnostic accuracy rate is approaching that of a reasonably trained general pathologist, 95%. Now, this is not because GI polyps are inherently easier or that Micro was significantly dumber than Pico. This is really just due to the pattern of training, building that framework using digital slide examples so that his competency and his confidence is much higher after a shorter period of time than it was with his earlier colleague. Well, this is just one domain, but I believe it can be transferred to other domains in surgical pathology and potentially even in clinical pathology, thus increasing the rate at which residents or trainees can attain competency. Well, another way to think about this is just to say, what do we do that can make teaching more efficient for the educators? Well, one thing, of course, is to create durable materials that allow you to do once and yet teach many. Provide circumstances or settings where the training is guided and adaptive, such as my experiment with the new first-year residents. Flip the learning paradigm, give the learners the responsibility to learn, set the goalposts and provide them the tools, but allow them to devour and master the material rather than spoon feeding it, as it were. And we can also make the types of materials that we have easy to update. So digital materials are notoriously easier to update than analog materials. On the learner side of things, by providing high quality, curated, and some quantity of content, they can attain mastery. So providing 10 examples of each of the various polyp types was part of the training program. We also can divide the learning experiences into smaller chunks. Cognitive overload, so to speak, the technical term, can be a discouraging or dampening problem on the learning process. So allowing residents to, trainees to do their learning in chunks of time when their mind is not otherwise occupied can also be very, very helpful. Of course, providing opportunities for pre and post-learning review to cement and, well, both initially establish the questions and to cement the learning afterwards is very important. And then providing compare and contrast options very readily, differential diagnosis comparison side by side and so forth, that also can make it more efficient for the learner. And then make that learning available anywhere, anytime, whenever they're ready. When the learner is ready, let the material be available. Well, what are some of the ways that this is being done? Well, one example of do once and teach many are the videos that Dr. Gardner and the blood bank guy have put together on their respective topics. These allow them to take common issues or common questions, synthesize them into a nice video presentation, and then when questions arise, readily refer their trainees to those videos or suggest them in advance as a sort of pre-learning or pre-exposure experience so that they have that foundational framework on which to begin to discuss and master and refine their learning experience. That's a great tool that's very underutilized. I've begun to use it myself, as you can see, and I think this is something that more people can and should do if they have access to quality materials and if they're going to be serious about teaching. For those who are members of the Digital Pathology Association, making these digital slide teaching videos is incredibly easy. So this is your interface. You load up your digital slides and maybe some PowerPoint slides, put them in the right sequence, hit this magic button up here, begin record, and speak into the microphone, please, because your words, your wisdom will be recorded for those who you want to teach. Once you push stop, the file is downloaded and you are ready to edit or even just directly upload it to wherever your outlet portal is going to be, or send it by email or other link to your trainees. Additionally, in doing it this way, you can provide that very important opportunity of pre and post review of the digital materials by simply providing the QR link or the QR code or the URL for that presentation. It can be de-identified so that diagnoses or other clues are not evident on the slides, or if you're using it internally, you can even preserve the file names and so forth. So this is a great tool, very powerful, and needs to be more widely used. Other ways of doing this, of course, are creating teaching sets, such as the DAPA high yield cases. That's one example. Here's another example from the OU files, teaching files launched by Dr. Fung, my colleague, and other institutions have similar files that can be made openly available. And the higher the quality here, the more robust, reliable the diagnoses, the more valuable, of course, the teaching experience. One example or one nice feature about the DAPA files, of course, is that in general, they've been annotated by the individuals who are creating and curating these so that you have the opportunity to review them as an unknown or to review them with the annotations in various settings. With regard to chunked learning, this can happen in a variety of formats on both the AP and the CP side. There's a vast number of Path Twitter folks that are sharing cases, materials very regularly. And this is a very simple example to just see nice, short, quick visuals of gross, micro, or video material that can be extraordinarily useful as you follow various individuals. And you can search topics using hashtags and so forth if you want to recall or bring things back. YouTube videos that I've referred to, and such as this one, another great opportunity to make learning available anywhere. They have a handheld device or otherwise. Kiko, a very useful pathology specific social media platform for sharing cases, finding information. We need more people providing content on there. So I'd encourage you on that front. And then tools like Anki, it's a slide, or excuse me, not slide decks, but card files, flashcards and so forth that can be shared and exchanged in clinical pathology or other domains. These kinds of things can be available for reviewing on the bus, reviewing in the bathroom, reviewing while you're brushing your teeth. Any of those things can make learning and teaching much more effective. So packaging what you're creating as a teacher into modules that your students can use and will use is very, very important. And if you're going to do it for a few, why not do it for many and make it very widely available to learners wherever they may be. Another thing that we can do to make teaching much more effective and efficient is by using the latest methodologies or the latest technologies to make the learning more powerful. So these interactive textbooks, so to speak, that Raj Singh and his colleagues have created using the Path Presenter format are incredibly useful for doing side-by-side annotations, comparisons, differential diagnoses, bullet point criteria, all linked to the slide annotations with the option to move the slide around and compare side-by-side these various considerations of differential diagnosis. Now, they've done a tremendous job with their derm textbook, but we need more textbooks like this. We need more of these digital slide-based text materials that can really provide the powerful comparative opportunities that is needed to develop a competent and capable pathologist. So can we accelerate the pace at which trainees are competent? Well, as I think you probably understand from my biases presented already, I think it can be. And will that or could that potentially lead to, as it were, early release from the confines of a training program into the wide world of work and patient care in a live and real setting? Well, this is a question that is worth asking, but there's certainly nothing that is particularly magical about spending 3, 4, or 5 years doing training. It depends a lot upon what you're training for. Depends a lot on how fast you learn. And we know that learners are individual, they are different. And so having a lockstep, rigid time frame may not be really in society or the individual's best interest in the world of personalized medicine. What about having personalized training? This is something we need to be actively thinking about and considering. So this paradigm between time-based or ability and competency-based is not old, but I would suggest that these time-based regimens have been largely proposed on the basis that the program is what's important. The institution is what's important rather than the learner. This is all oriented towards what's manageable as a program. So cohorting them, organizing them around blocks and times and so forth are what the program does. And this is where, of course, the milestones and the board requirements usually come along together in these time-based programs. Now, advanced trainees will, of course, continue to add skills and increase their depth. They will become much more colleagues and consultants than they will be trainees as they reach the latter stages of their training. But there's not a great incentive for them to really keep pushing on that to attain that. Now, of course, we have progressive responsibility and entrustable professional activities that can be incorporated into this to encourage and facilitate that continued progression. But at the end of the day, you know, we take in a cadre of trainees on one point, we spit them out at the end at the other point, and we sign off on their competency and their readiness to take the boards and be unleashed on the public, knowing full well that they are at vastly different levels of competency and training. Yes, they have met the minimum standard, but there's a dramatic difference. So an ability-based program would be based on defining the skills or the competencies by assessments of performance. There could be variable exit points and entry points. Now, this would, of course, complicate the program structure, but this is much more learner-oriented training. And there are, with this, incentives, therefore, to demonstrate competency sooner, because those self-paced learners could then excel, graduate early, go on to other activities or training that could allow them to further hone or prosper their career, push outward the envelope of science and so forth. Well, how could we do this? Well, in a time-based setting, I've already illustrated that we can standardize the content, we can structure it in ways that define competency. We can, again, make sure the goalposts are very clear, that these milestones are concrete, that the competencies, the skills we're expecting are there. We can increase the content density as we provide more structured and tailored, individualized learning. We can work towards more robust and standardized measurements to ensure that we do reach those levels of competence we want. And there can be some incentives for people to continue to learn. In my program, you know, you had maybe a little bit more elective time, or you had higher level of entrusted activities, such as frozen section sign out or coverage at night, and so forth. In a skill-based setting, so-called flipped residency, yes, you're going to use standardized content, you're going to enrich the resources, define the goalposts, but there you have the potential for early step up into next phase work. And that's very, very important as we want to think about creating capable and competent, safely competent pathologists. So, of course, one of the ways to do this is to go digital. That, of course, is the purpose in discussing this at a Digital Pathology Association setting. So what are the things that allow us to do that? Well, there are, of course, digital slide box, courses, tutorials, and conferences that avail themselves of these things. Digital slide publications, of course, can do this. There are atlases, journals, texts, Path Presenter, and so forth. Digital slide assessments can be used to validate these things. And in all of these, the digital environment allows residents much easier access to pre and post learning experience review and study. These allow us to use those materials to create these mental frameworks, like my lower GI polyp tutorial, and also allow us to use these micro learning moments beyond just structured didactic conferences once or twice a day. On the clinical pathology side of things, there are a number of digital resources, virtual resources that are out there, such as the TRIG program, LMU, and Path Informatics University. Cell-Vision Cell Atlas is there. The CAP Hematology Atlas is digital. Urine sediment teaching can be digital and virtual. Additionally, immunoelectrophoresis and other slide deck sorts of things can be provided for ClinPath topics. And there can be virtual exercises in clinical lab problem solving. In fact, the virtual exercises may be easier to do in clinical pathology than they are in AP because the virtual environment doesn't depend to quite the same degree on some of the other features. But these can be structured, case studies and so forth that can really prepare people to manage call settings, manage live laboratory issues. And then, of course, in various informatics tools, we've talked about those up here as we alluded to those types of training. Well, then for many of these sorts of things, there's an app. So take a look at the Cell-O-Vision app. Take a look at the Identify Bacteria app. These are very useful learning tools for morphology, for function, for identification, and are generally available at no cost that can be done. There are on the AP side a number of very, very useful apps. I would call out particularly the Hopkins atlases, such as the Pancreatic Atlas or Cytology Atlas. Those are incredibly useful tools with very rich images, nice algorithms, worksheets to work through, and so forth to cement your visual knowledge. So I think they're becoming a new standard. Additionally, there are many digitally empowered textbooks. Now, this may not be rocket science, but it certainly makes learning hematology rock. And my hat is off to Dr. Eric Glassy, who's pioneered this work and championed it quite relentlessly. So in the Hematology Atlas published by the CAP, Dr. Glassy has required them to have a QR code linking to the digital slide. You're looking through the textbook, virtually or otherwise, you scan the QR code with your phone or other device, and immediately it can take you right to the digital slide so that you can observe these cells in the context where they have existed. And this is something that really can be very important and something that is important. In fact, in a study that we did a few years ago, it was demonstrated that residents retained and were able to apply more readily the criteria that they had observed from published articles if they had been able to also allow examine the digital slide, interact with it, and see the broader context in which that finding or those circumstances were presenting. So giving people the context beyond just a small window into a few clustered cells is very valuable. So let's go to the next question here. How do we make pathology education more available? And this is where my passion becomes almost intense. I think it's time for you and I and Buzz Lightyear to go to infinity and beyond with what we're doing with pathology education. So how are we going to do that? Well, on current projections and program sizes, this gap in the US is going to continue. I cited the more recent study of actuality in terms of vacancies, but this gap is expected to continue on over a continuing number of years, because you can see we are here just at the beginning of the decade, and this gap continues to widen over the coming years. That's not a trivial loss of manpower. And of course, we've been filling some of the gap in terms of attracting students by taking in international students, which is, again, counterproductive to their manpower gaps in pathology and otherwise. So we don't want to be part of making the problem in the developing world worse by being a cause for brain drain. We need to attract more students into pathology, both domestically as well as internationally, so that both of these problems can be addressed appropriately. Now, we could ask ourselves, what might we get out of AI? Well, multitasking, of course, has become the norm in the digital era. But given the projected cancer burden increases of up to 40% over the coming decades, it seems very unlikely that AI alone will be able to manage that increase on a broad scale. We've certainly seen some promising helps recently released AI tool for prostate. There are many others under investigation and validation that we've had presented or discussed by vendors and others at this conference during the past week. But at the end of the day, a pathologist's signature is going to go on the report. They're going to be the one validating and verifying that even using that tool appropriately, that's the right diagnosis for the patient. so that then the treatment, the cure can begin. It isn't going to happen without a pathologist. And we're not going to have a doubling of efficiency that's going to mitigate this manpower gap that we are looking at, even with very optimistic capabilities for AI. So we know that virtual training, however, is very, very possible. And COVID-19, it may turn to be a great blessing to us for simply this fact that we have learned how to do so many other things virtually without the need for direct face-to-face contact. That I can be speaking to you in this manner, virtually and asynchronously, is itself a testament to the fact that learning can happen in a virtual environment and still be quite effective, because I will take a little surmise that you've already gained some things from this presentation. So what kind of core teaching might go virtual and asynchronous? On the ClinPath side of things, certainly core knowledge of instrumentation and diseases. That's kind of basic knowledge of scientific principles, instrumentation principles, and so forth. Problem solving with practice cases, troubleshooting sample problems, and learning any of the other core principles and associated didactic content about various diseases or subspecialties could certainly be virtual and asynchronous. In other words, I give it here and somebody in Rwanda can view it, 3 weeks from now, or 3 months from now, or 3 years from now, and have it still be valuable. On the AP side of things, there's lots of didactic content that people have been accessing asynchronously and virtually. Many of the recent pathology meetings have provided didactic content, updates, and so forth that were available virtually as well as asynchronously to those viewers who wanted to come back later. Additionally, morphologic microscopy skills can be taught using video microscopy, using digital images and digital slides to enforce pattern recognition. Unknown conferences, which we've done on our channel, can be presented in a virtual and asynchronous or synchronous fashion. And learning how to understand the disease, to generate reports, these again can be done asynchronously. Of course, it helps to be able to ask questions and to provide feedback, but much of this can be done in an asynchronous manner. Well, what could happen remotely but might need to happen synchronously? Well, on a ClinPath side of things, certainly assessment of someone's live problem-solving ability and management of active patients, management, mentoring, and so forth would be best accomplished in a synchronous manner. And certainly any live patient management, that would be true for either side of things. Grossing skills need to be done synchronously. You don't want to make a mistake in this. But many of those skills can also be learned asynchronously, such as by providing a video of someone doing it wrong and asking them to identify where the mistake occurred. Those kinds of trainings can be done in an asynchronous fashion. But FaceTime, other live streaming, video calling can enable this grossing skill to be taught from afar. Frozen section interpretation of live cases, that can happen in a remote fashion. The very beginnings of frozen section digital pathology, telepathology involved these kinds of cases. Rapid on-site cytology training. My colleague, Dr. Fowl, and some others here have talked about streaming microscopy for on-site evaluation in a nice recent publication and poster, and similarly management. So these are most easily accomplished in a digital pathology environment with digital slides and digital slide capability and the associated Zoom and other digital streaming video type of setting to make them most engaging and most facile for evaluation. So what I'm proposing here ultimately is a three-pronged approach to impact the problem. We do need to continue to work to enhance productivity. This is where our augmented intelligence, where technological and workflow changes can increase our productivity. We need to accelerate competency in existing programs and think about ways that that can be used to leverage an increase in our trainees and practitioners. And finally, I think we need to be able to expand training to allow virtual availability worldwide so that a greater number of both training programs can exist and trainees can be accommodated to meet that dramatic need. Well, at the end of the cartoon, you know, they fade to the end with the happily ever after. This story certainly could be the happy ending to the COVID situation. If, because of COVID, we have learned how to solve this problem, how to provide education remotely, how to train an increased number of people, we may have discovered a solution to a much greater crisis than just a viral pandemic, and that of the pandemic or the epidemic of non-communicable diseases that faces the world. So what are some of the next steps? Well, we want to optimize and be thinking about how we can promote the use of digital resources in pathology education. The DPA is very active in this. DAPA is one of the solutions. There are others that we're working on to attract medical students and so forth. We want to, and we probably need to, begin to curate and organize these existing open access materials in a manner that makes them readily available, keeps them current, and provides some level of, how should we say, filtering for serious trainees. Because we don't want to expose and waste the trainees' time with bad materials. We need to create some remote training pathways to begin to fill these manpower gaps and provide care where none has been available. The difference between some pathology care and no pathology care is desirable. Even if we can't get it to highest Western quality care in the first step, that early innovation of competing against non-consumption and providing some service that is better than nothing is valuable. I think here of some of my colleagues in Laos and elsewhere, and situations there where surgical specimens are discarded without any trip through the pathology lab because simply there is no pathology lab that's available and which patients can afford and which is appropriately staffed by somebody who knows the first thing about what they're looking at. And then finally, as we do that, we're going to need to work with the accrediting, credentialing, and licensing bodies in these regions of high need to promote acceptance of these virtually trained pathologists and to make sure that what is being provided is suited to their environment and their needs in that setting. Well, if that's something you're interested in joining me on, please contact me for further information. We are eager to get this word out, to get this process moving forward, and to truly create, as it were, an avalanche of materials and pathways so that the world can know and receive the benefit of trained pathologists. I've had some help in this presentation preparation from the education committee, and one of the things we've done is to prepare a manuscript, which will hopefully be soon published, that details some of the learning resources that are available for various disciplines at present. This is slightly curated, not fully vetted, but certainly reasonably reliable based on the materials that we're aware here. This example from cytology, there are similar tables on autopsy and surgical pathology that will appear in the paper, and which I'll be happy to provide to you as a preprint if you would like. So in closing, let me just thank the many people who've contributed to this effort. Here's a lengthy list of my co-authors on this project, and very, very capable and dedicated people with great motives, great experience, great teaching skills involved, and they are wonderful to work with. So with that, we come to the end of this program, and I thank you for listening through to the end. My contact information is in the information below, of course, if you'd like to reach out to me and get further information about the Alliance to Increase the Global Pathology Workforce, or participate or comment in any other way, please don't hesitate to reach out to me or any of the other people that have contributed to this. I'm sure they also could provide insight and input for you as well. So until next time, thanks so much for joining me.